Good evening, everybody. I am Paula Dabney, and I have been doing the disease cystic fibrosis. I chose cystic fibrosis this semester because of what I do for a living. I'm a respiratory therapist. I've been a respiratory therapist for 17 years. I have learned a lot about cystic fibrosis that I didn't know. I knew a lot about the disease as far as the symptoms and the things that they do, the disease itself does to you and the way that you treat it. I was not aware of the way that you get it and the way that it affects your body as far as your genes go. Cystic fibrosis is a progressive genetic disorder. There are a lot of different things in your body that it can affect. You can have a sweaty chloride test. The first pathologic description of the disease happened in 1940. Then they had a discovery of salt in the sweaty of your skin. Then there was a chloride test developed in 1960. And then all of these things, airway clearance, antibiotics, anti-pseudomonal antibiotics, rhDNase, inhaled tobramycin, high-fat diet, enzymes, all these things up till 2015 have helped with the progression of helping with CF. Some characteristics of cystic fibrosis, some symptoms: very salty tasting skin. That's how they actually diagnosed the disease a very long time ago. Persistent coughing. At times, some phlegm comes with that. Frequent lung infections, including pneumonia and/or bronchitis. Wheezing, shortness of breath. Kids with CF don't grow well. They don't gain weight. They have a very good appetite, but they just don't gain weight. Frequent greasy, bulky stools or difficulty with bowel movements. Males, a lot of times, are infertile. Gastrointestinal and nutritional manifestations of CF. Stricture and/or dilation of the distal small bowel is often associated with meconium ileus. Distal intestinal obstruction syndrome, DIOS, previously termed meconium ileus equivalent, is episodic, partial or complete bowel obstruction later in life because of the retention of the viscous secretions and the fecal material in the distal ileum and cecum. DIOS affects 15 to 20% of adolescents and adults with CF, and a somewhat smaller proportion in children with CF. Up to 40% of young infants diagnosed with CF through newborn screening may have fecal fat balance consistent with pancreatic insufficiency. This suggests that many CF patients lose pancreatic function over the first several years of life, rather than being pancreatic insufficient from birth. Exocrine pancreatic insufficiency is caused by insupposition of secretions within the pancreatic ducts and poor growth. Malabsorption of fat-soluble vitamins and zinc results in hemolytic anemia, defective coagulation, and skin rashes as specific manifestations of these deficiencies. Pancreatic enzymes, however, intact secretion of salivary amylase and gastric proteases results in partial sparing of protein and carbohydrate malabsorption. This is a schematic representation of the CFTR and the position of some of the most common CF-associated amino acid variants. Cystic fibrosis is a fatal disease caused by a defective gene that produces a mishapen form of the cystic fibrosis transmembrane conductance regulator protein, CFTR for short. People with cystic fibrosis do not have enough CFTR for their cells to work normally because their bodies quickly destroy the mutant protein. The deletion of this protein specifically occurs in major domain of the CFTR called NBD1. Earlier, experimental studies have shown that the mutant NBD1 has an increased tendency to misfold, resulting in the premature degradation of CFTR. In cystic fibrosis, the molecular basis of this increased misfolding tendency has remained elusive, said team leader Nikolai Duckelhayen. Understanding molecular etiology of this disease is a key step to developing pharmaceutical strategies to fight this disease. This is a small pedigree showing an illustration of how unaffected parents can be carriers and the production of children. An unaffected child has a 1 in 4 chance. An unaffected carrier has a 2 in 4 chance of producing an affected child. And an affected child has a 1 in 4 chance. This is a small pedigree, a simple pedigree that I put together for some inheritance patterns of cystic fibrosis. It shows a male and a female. They have a 1 in 2 probability of having a child that has cystic fibrosis. Dad is not affected. Mom has the disease. They have a daughter that has the disease, a son that does not. They have a daughter that has the disease. She marries somebody that does not have the disease. They have a son that is not affected. These two have 3 children. None of those children are affected with the disease. These two, one has the disease, one does not. They have 4 children. 1 with the disease, 3 without. These two have 2 children. One, a girl without the disease, and a boy without the disease. They have 2 children without the disease, but one is a carrier. This girl is a carrier. Genetic testing. CF gene mutation testing is also known as cystic fibrosis genotyping, CF DNA analysis, CF gene mutation panels, CF molecular genetic testing, CF fibrosis transmembrane conductance regulation mutation analysis, CFTR mutation analysis. Why get tested? To detect CF gene mutations, to screen for or diagnose CF, to determine whether you are a carrier or a CF genetic mutation, and to evaluate the risk of having a baby with CF. When to get tested? When screening newborns for CF, all U.S. states screen for CF, and some states use this test for screening when older children or adults have signs. Sample required. A blood sample is drawn from an infant's heel by collecting a spot of blood onto a fiber paper. For older children, a blood sample is obtained by inserting a needle into a vein. Possible breakthrough in cystic fibrosis. A new partnership in the UK will develop a gene therapy for cystic fibrosis that could treat the disease with a single dose. This is an illustration of your trachea, your lungs, smooth muscle. This is a healthy illustration of smooth muscle. This is mucus. This is your trachea muscle. Over 1,700 different mutations have been identified in the CFTR gene that can cause cystic fibrosis, and gene therapy may be the most effective way to combat all of them at once. Nonetheless, gene therapies for treating cystic fibrosis are still in the early stages of development. In 2015, the UK Cystic Fibrosis Gene Therapy Consortium was the first to show that repeated doses of a gene therapy delivered in fat droplets could be effective in treating cystic fibrosis in a phase 2b trial, but the therapy was not equally effective in all patients. Gene therapy is not the only approach biotechs are using to treat cystic fibrosis. For example, the Dutch are developing a drug that binds to mutated RNA to restore the production of healthy CFTR protein. Verona Pharma recently obtained positive phase 2 results for a drug that simultaneously inhibits two enzymes in order to reduce inflammation, clear mucous membranes, and dilate the lungs. There is a great deal of testing that is going on that is looking up for cystic fibrosis patients.